And the natural course of disc herniations is they resolve in size. Not just the symptoms, but the disc herniation itself resolves. And the larger the herniation, the more they resolve. I'm going to provide you, since this comes from a 12-hour course I've given around the world, albeit I'm a little bit out of data, some of my stuff in my book. I'm going to give you a QR code later that will give you free access to a five-hour class in the U.S. I don't know if we have European CEUs, but for U.S. we get that too. It has a 400-page book that goes with it, and all these videos, and it's pretty exhaustive. So you don't have to take images. All this information is in that book. So this is what we're talking about. Lumbar disc herniation, L5S1, no, L4, L5, forgive me. So here's this huge herniation right here. Patient came to me. She worked for our U.S. government. She traveled around the world inspecting drug factories, going to China, going to Australia, long flights. She comes to me, and she's got a promoter, she's got nerve tension findings, little reduced reflexes. Motor was intact, urinary and bowel control was intact. Should I treat her or should I refer out? Reduced reflexes, motor's intact, urinary and bowel's intact, really tight SLR. So here's her 5 months later under conservative care. That's to be expected. Huge herniation. If she had seen virtually any other neurosurgeon in her hospital, that they would have put her on the table. She really couldn't tolerate a chiropractic adjustment initially. As you can see, that's pretty large. Again, here she is. Let me get that picture. There she is, before and after. So start off with managing her neuros every week. Extends her hallux longus, hip anterior, gastroc, reflexes, and dermatomes. But you don't operate on people for reduced reflexes. You don't operate on people for nerve tension signs. If the motor's intact, you're safe to go. That's a good idea to have a neurosurgeon with you. Certainly if there's progressive weakness, you want to make sure you're not the senior person with that secret. You want to make sure you collaborate with that, which is part of what we stand for at WFC, EPIC. In fact, at our university, every incoming student signs our mission statement, which essentially is EPIC, evidence-based, patient-centered, integrated, collaborative. So they come to our school, and they come back, if the wizards come to me later and say, Doc Morgan, this ain't real chiropractic. You knew our culture going in. This is what we teach, this is what we're abiding by, this is what we're about. But 5 months later, that disc had regressed. It's pretty good, right? So again, this is not standard of care. I actually have maybe a couple hundred of these cases pre and post. So since I took care of military folks, I justified, at least in my head, if I've got a Navy SEAL in a time of war in my office with herniated disc, and I know they're better, I want to make sure he knows he's better. So I took the post pictures like, you're better than you were before. This is better than if you'd had surgery. Got it, Doc, we're back in the field. 25-year-old Coast Guard officer, female Coast Guard officer, marathon runner. She herniated her disc, and let me help you out here so you can see it. All these are L4, L5s. You know, most of them happen at L5S1. So here she's got this disc. She felt better at the first adjustment, but again, I took the pictures 5 months later. The disc had regressed. 61-year-old, very senior member of our government, herniated disc. He was referred to me by a neurosurgeon. His, it was I think L1, L2. He had a really tight tension sign for his femoral nerve. He just really was tight there. It's going to be like Eli's really lit him up. So again, 5 months later, I took the pictures. I'd probably do it in 3 months. Now, if you're 61, you're much less likely to regress than a younger person. And I'll talk about that. Water-filled disc herniations absorb at a much faster rate than old dried-up disc would have. But in this case, he did regress. So here's that disc herniation. Let me get a better picture. There's that disc. It filled in with scar tissue. You can see there. And if I used gadolinium, I would have lit up with scar tissue as well. But you could even have someone who's older will regress. And if you get a sequestered fragment like this, their sequestered fragments always regress. If you get a broken leaf fragment, they're going to regress. Even if you inject them with steroids that turn off the inflammatory nerve response. So here he is, here's a disc here, nothing huge, you've seen bigger ones. There's that disc facing the cord, or not cord, forgive me, the thecal sac. So it's pretty hot, pretty inflamed, a lot of pain. And then here he is, 5 months later. Disc, it's reabsorbed. So it's pretty good news. Here's actual image of them. Most of my images I use are TQ-weighted MRIs. So, and how I learned MRIs, I'm not a radiologist, but for my first 3 years at Bethesda Hospital, I did morning report with neurosurgery and neuroradiology. So I had some pretty good instructors for helping me read MRI. But you can see that right there. You're facing the thecal sac and pretty much resolved. Now here's a good case. So here's this huge herniation, sequestered fragment. It's full of fluid, and the margins around the disc herniation have shown great contrast. Everything you see for a disc that's going to reabsorb. That disc, I can guarantee in 5 months it'll totally reabsorb. It's huge. It's water-filled. It's got inflammation. By having the contrast at the edge, it shows there's a lot of inflammation there and your body's consuming it. The problem is, they've taken out the S1 nerve root. This person can't wait long enough for that to resolve. It would have permanent nerve impairment. So though they're gonna get better in time, it's your job to make sure this one needs to go to the neurosurgeon. And this one had a neurosurgical outcome, and the neurosurgeon said the disc practically fell out. It was sequestered fragment, came out, immediate relief. So it's our job to make the correct referrals. Now I'm showing you optimistically they can get better, but they also can get worse. It's your job to make sure you understand that neuro exam and is so comfortable that you can do it in your sleep. And in the video, there's a video in